The third part is the pancreatic duct stenosis. How about the EUS-BD after the ERCP intubation failure? The first successful case of EUS-PD is published in Endoscopy in 1995. A 48-year-old male patient with tumor and recurrent pancreatitis. It was initially considered the tumor caused pancreatitis. 2 years later, EUS-BD implementation identified that the failing defect in the pancreatic duct was a stone. Well, the stone was the cause. EUS-BD can be directed change the pancreatic juice through the gastric wall. By stand, it can also be performed EUS-RV technique. The stand can be a plastic one or special metal stand are also available. The left figure was that the pancreatic duct drainage was performed by EUS-RV technique. And the right figure is show the patient with the pancreatic intestinal and anastomotic stenosis underwent transpapillary pancreatic drainage on the US guidance. From this research is published in 2017. 80% were treated with EUS-BD in 4 academic centers in 3 countries. The results show technical success rate was 89% and clinical success rate was 81%. This picture shows the process of the treatment. This article published in 2019. Endoscopic transpapillary or trans-anastomotic pancreatic duct drainage is the mainstay of the drainage in the symptomatic pancreatic duct obstruction or leak. However, transpapillary or trans-anastomotic PD can be technically difficult due to the tight structure or surgical altered anatomy. The EUS-PD is now increasingly used as an alternative technique. We know there are 2 techniques in EUS-PD: EUS guide reverse EUS-RV and EUS guide transmural drainage EUS-TMD. In the case of the normal anatomy, EUS-RV should be the first choice. The total technical success and adverse events rate was 78% or 21% respectively. The technical success rate of EUS-RV is about 40% lower than EUS-TMD. Now, I show a case. 1 month ago, I completed the case of the treatment using EUS-RV technique. The patient's first admission. 3 months ago, the patient has jaundice due to the pancreatic malignant tumor invading CBD. Before admission, ultrasound guide external drainage was performed. After admission, EUS-FNA was performed. Cytological examination and pathological findings suggest the pancreatic cancer. And then, after surgical consultation, the patient was unable to perform the operation. A metal stand was inserted. Before the second admission, the patient had abdominal pain and increased amylase. CT scan results show that the boundary of the pancreatic body and tail was blurred, and the pancreatic duct was dilated. ERCP was tried first, but the duodenal papillary were not found. We decided to perform the EUS-BD. EUS-RV technique should be selected first. Under the EUS scan, the dilated pancreatic duct can be seen. The puncture was successfully and the pancreatic juice was extracted. Insert the guide wire and adjust the direction to send the guide wire into the intestinal cavity. Then, change the duodenoscopy and the plastic stand was inserted by standard ERCP procedure. On the next day, After treatment, the patient's abdominal pain was relieved and the patient amylase decreased to normal. This is a video of our treatment procedure. You can see dilated the pancreatic duct. The puncture the pancreatic duct. The angiography shows that the dilated duct, pancreatic duct, and insert gut wide. Adjust the angle. Attempt several times and push the gut wide to the intestinal cavity. This is not easy. Okay, the gut wide, we're pushing to the intestinal cavity. We train the duodenoscopy and inserted and capture the gut wide. And then insert the plastic stand in the standard ERCP procedure. The puncture site is no bleeding. Finally, I make a summary. ERCP EUS and PTCD are important tools for the treatment of the biliary and the pancreatic disease. These two techniques have different indications and also complementary each other. For distal biliary duct stenosis of the ERCP and intubation failures, EUS-BD or PTCD can be selected. With the patient have the higher biliary stenosis, ERCP and PTCD are all effective treatment techniques. But for Bismarck's 4 types, PTCD is safer and more effective. If the patient failure in ERCP intubation in the pancreatic disease, EUS-BD is a technical option. Our team proposed the concept of intrahepatic biliary canalization and the served technique. Today, I suggest, from technical point of view, the EUP platform as the ERCP EUS PTCD, one step to resolve the patient's problem. The EUP platform can be better solve the biliary and the pancreatic disease.